Welcome back guys. Now in this video let's discuss about the topic of female factors of infertility. Already we have completed male factors of infertility. Now in this video let's discuss about female factors of infertility. Now guys, when a female comes to the clinic, okay, the male and female they came to the clinic. Now what is that first investigation we will be doing in them? We have already discussed in an infertile couple all the time we will be taking the history and we start the investigations with the male partner, that is semen analysis. Please concentrate here. The basic evaluation to be done in infertile couple is first we have to take the history and do the physical examination. That's the evaluation. And we have to start the investigation with the male partner, that is we have to do the semen analysis. Now if there is no problem with the male, we are thinking about the infertility is because of the female. Now in female, what are the investigations to be done? Generally, we will be doing the tests of ovulation, which means we just want to know whether the female is ovulating or not. Is she having any problem with the anovulation? So we all know that anovulation is the most common cause of infertility. That is the anovulatory infertility might be because of the PCOS like conditions. So we just want to know whether she is ovulating or not. After that, there might be problems with the ovarian reserve, which means in her ovaries all the follicles got exhausted. Okay, so that is a premature ovarian failure. So we just want to know whether she is having good number of follicles or she have entered into premature menopause. Also we'll be taking care or just like we will be checking her fallopian tube, whether the fallopian tubes are patent or they got any blocks. Okay, now history taking is very much important because just with a proper history taking, we will know whether she is having any problem or not. We can know what exactly the problem just even with the history taking. Now in the history, what exactly we are going to ask? We are going to ask the age of the female. Why? Because if she is getting near to her 40s, if she is a 40-year-old, a 37-year-old, we should be concerned about her ovarian reserve. The more the age of the female, the less likely chances that she will get the pregnancy. We all know, more the age, less number of follicles will be there. She might be entering into premature menopause. We will be also asking about the menstrual history. Why menstrual history is important? Why? Because if she is regularly menstruating, which means the cycles are ovulatory cycles. If she is saying that I am bleeding once in 3 months, it indicates us that her cycles are irregular cycles, which means there is a problem with the ovulation. Anovulatory cycles will lead to irregular bleeding. Now, the amount of bleeding is also important. Why this? Because, for example, if she says, Doctor, I am bleeding so much. If she is bleeding so much, I should be concerned about uterine fibroids. We all know if she is having fibroids, something like submucous fibroid, she will be having so much amount of bleeding and this submucous fibroids will also affect the pregnancy. So in her, the infertility is because of the submucous fibroid and this too much amount of bleeding is also because of submucous fibroid. We can know something like that. Now if she is saying dysmenorrhea, for example, what exactly is dysmenorrhea? Pain during menstruation. Now we will know that if there is so much amount of pain, this might be because of conditions like endometriosis. In endometriosis, there will be so much amount of pain, that is congestive dysmenorrhea at the time of menses. We also know that endometriosis will cause infertility because of the distorted tubo-ovarian relationship, because of the adhesions that can lead to infertility in the conditions of endometriosis. If she is saying dyspareunia and also she is having infertility. Now usually dyspareunia is associated with which kind of gynecological conditions, right? It is associated with many conditions, but dyspareunia is seen in endometriosis also. So endometriosis, distorted tubo-ovarian relationship. In endometriosis, pouch of Douglas is going to be affected. The second most common site for endometriosis is pouch of Douglas. So whenever she had this intercourse, she will be having dyspareunia. So if she is saying, Doctor, I am having dyspareunia, also I am suffering with infertility, I will be thinking about endometriosis. And if she is saying, Doctor, I am having pelvic pain, and also I am suffering with infertility. If she is saying pelvic pain, this pelvic pain might be because of endometriosis. This pelvic pain might be because of some pelvic infections like pelvic inflammatory disease, because of the adhesions, because of the 𝗑𝐬𝐼𝐻𝐾 syndrome, there can be this pelvic pain. So I also have to ask her whether she had any previous history of pelvic inflammatory disease, previous history of genital tuberculosis, thyroid disorders and galactorrhea. All of them can contribute to infertility. So history taking is very much important. Okay, after history taking, let's see what are the main female causes of infertility. The female causes of infertility are classified into 4 types, that is ovarian causes, tubal causes, uterine causes and unexplained causes of the infertility. Now important is that let's start with the ovarian causes, which almost account 40% of the cases of infertility. Now if I am saying ovarian causes of infertility, what actually I mean by it is that there is some problem in the ovaries. What is that problem in the ovaries? Now these ovaries, the ova inside these ovaries are the follicles inside these ovaries, they are not ovulating. That is anovulatory problem can be there, or there might be decreased ovarian reserve, that is premature menopause. So the 2 main problems in the female in her ovaries are, it is either anovulation or decreased ovarian reserve. Important point is that, see, anovulation accounts for most of the cases. In 85% of the cases, the infertility is mainly because of the anovulation, and we can easily treat this anovulatory infertility. So which form of infertility is easily treatable? Anovulatory infertility is easily treatable, and also we know the most common cause of anovulation is polycystic ovarian syndrome. Now after this, let's see whether the female is ovulating or not. So what's the main problem, guys? Anovulation. So how to know whether she is ovulating or not? So there are certain tests for ovulation which includes the basal body temperature method. Guys, let me tell you one thing. In a normal female who is having ovulation, there will be biphasic temperature pattern, which means in the first half of the menstrual cycle, the basal body temperature is comparatively low when compared to the second half of the menstrual cycle. Okay, so first half of the menstrual cycle, the basal body temperature is little bit low, that is 0.5 degrees low when compared to the second half of the menstrual cycle. So what I am trying to put into your mind, if there is ovulation, now she will be entering into the second phase, then only her body temperature raises. So in ovulatory cycles, at the time of ovulation, the basal body temperature is raised to 0.5 to 1 degree centigrade. But if she is not ovulating, whenever she is not ovulating, there is no biphasic pattern. The temperature is going to be constant. Okay, so this is the one important point I want to put into your mind. In anovulatory cycles, there is no raise in the temperature, and temperature is going to be constant throughout the cycle. Okay, now the second test is the cervical mucus study, which means we are just examining the cervical mucus and we are going to come to a conclusion that whether she is ovulating or not. How this is possible? Why? Because see, in the proliferative phase of the menstrual cycle, there is the cervical mucus consistency. The cervical mucus consistency is a bit different when compared to the secretory phase of the menstrual cycle. What does that actually mean? See, in proliferative phase, under the effect of estrogens, the cervical mucus is more stretchable. If you take the cervical mucus and if you put it under the microscope, this cervical mucus will show furning or spin burkitting. Okay, so important point is that spin burkitt sign and stretchability and furning, these are seen in the first half of the menstrual cycle under the effects of estrogens. Now, what happens normally? So, whenever ovulation happens, because of the progesterones, whatever are there, see, under the effect of progesterones, the cervical mucus will become thick and viscous. Now, in our female, In the second half of the menstrual cycle, you just take the cervical mucus and you examine it. If it is still having stretchability, if it is showing firming, which means ovulation not happened. If ovulation is happened, the cervical mucus will become thick. If ovulation not happened means this firming and stretchability will be seen in the second half of the menstrual cycle also. So, firming and stretchability beyond 22nd day of the menstrual cycle means anovulatory cycles, ovulation not happened. Okay, that's a very important point. Now, the third test is the vaginal cytology. So, just by looking at the vaginal epithelial cells, we can know whether the ovulation is happened or not. How, sir? Guys, we all know that the lining epithelium of the vagina is stratified squamous non-keratinized epithelium, and this epithelium was laid in 3 layers, that is the basal cells, intermediary cells and parabasal cells. Guys, let me show you. See, this is the basement membrane. These are the basal or parabasal cells, and these are the intermediary cells which are stuffed between the superficial cells. These are the superficial cells. Okay, I'm just they are not accurate. I'm just showing you to get an idea. So you will be having superficial cells, intermediary cells, basal or parabasal cells. What is that important point? Superficial cells are more in number during estrogenic dominance, that is proliferative phase. Intermediary cells are more in number during progesterone predominance. So, progesterone predominance means luteal phase. During luteal phase, progesterone will be there and more number of intermediary cells will be there. Now, see, I am just asking the female to come in the second half of the menstrual cycle. Now, I am just going to take some vaginal epithelial cells and I will be seeing. See, if she is ovulating, think logically. If she is ovulating, there will be progesterone, and under the effect of progesterone, there should be more number of intermediary cells. But in second half of menstrual cycle, if there are more number of superficial cells it means ovulation not happened, anovulatory cycles are happening in this female. So, please concentrate. After ovulation, under the effect of progesterone, okay, there should be more number of intermediary cells. So, persistence of superficial cells in the second half of menstrual cycle indicates an ovulation. Okay. Now, after this, there is one more test with which we can know the ovulation. That is the endometrial biopsy. Guys, we all know that in second half of the menstrual cycle, that's the secretory phase of the menstrual cycle. That's the secretory changes happening in the endometrium. Now, in the second half, the endometrium and the endometrial glands should undergo the secretory changes. So, if I take a biopsy in the second half of the menstrual cycle, the endometrium should be secretory in nature. But in the second half, if I take the biopsy, in the biopsy report, it came that proliferated endometrium, which means secretory changes are not happening. Secretory changes are not happening means there is no progesterone. Why there is no progesterone? There is no corpus luteum. Why there is no corpus luteum? There is no ovulation. So, important points, guys, please concentrate. In the second half, there should be presence of secretory endometrium. If there is secretory endometrium, it indicates ovulation happened. Now, the endometrial gland should be in corkscrew appearance. They should show you corkscrew appearance or sawtooth appearance. And there should be changes like subnuclear vacuolization. Guys, the subnuclear vacuolization is the first sign seen in the secretory endometrium. And also there should be stromal edema. So, stromal edema is an indicative of secretory endometrium. Absence of any of these features indicates that the endometrium is a proliferative endometrium, which means ovulation not happened. And the last important test of the ovulation is hormonal study. So, what exactly is this hormonal study, guys? Very important. Guys, if ovulation happened on 14th day, there will be corpus luteum, and from the corpus luteum there is progesterone production. So, I am going to check the progesterone levels on day 22nd. If progesterone levels are more, that is more than 3 nanogram per ml, progesterone is there, so ovulation happened. If serum progesterone levels less than 3 nanogram per ml, it indicates ovulation does not happen, that is anovulatory cause of infertility. Okay, now see, we have seen so many tests of ovulation. Out of all these tests, out of these 5 tests, what is the best test? Okay, so very important MCQ. The best test to detect the ovulation is hormonal study. That's the serum progesterone levels. But if they ask you what is the best test to predict the ovulation, what does I mean by? Guys, there is this female, okay, there is this a newly married couple, and they just want to know like when she is going to ovulate, so that if they participate in that particular time, there are more chances of getting pregnancy. Okay, so there is this couple who just want to get a pregnant. Okay, the female want to get the pregnant. So what they will be using is these LH kits. So if you put a urine drop into this LH kit, if it shows positive, which means that there is LH surge happened in this female. When LH surge happened, we all know within the next 36 hours, she is going to ovulate, right? So from the LH surge to the ovulation, it takes like 36 hours, right? 32 to 36 hours. So in the next 32 to 36 hours, she is going to ovulate. So the best test to predict the ovulation is LH. It's just like urine pregnancy kits. The female will be going to carry this LH kit, and she will be knowing when she is going to ovulate. Okay, either she can have intercourse in that particular time if she is willing to have the pregnancy, or she will be avoiding the intercourse in that particular time if she doesn't want to get pregnant. Okay, so these are some important points. Now, how to treat an ovulation? For example, you came to a conclusion that she is not ovulating. Now, what you have to do? You have to make her ovulate in order to treat her infertility. She is not ovulating, you have to make her ovulate. So, how we are going to do that? By giving ovulation inducing drugs. Guys, the treatment, very important, the treatment for anovulatory infertility is ovulation inducing drugs. Before discussing all the ovulation inducing agents, let me show you some important image based questions. They can simply give you the endometrial appearance, ultrasonographic appearance of the endometrium, and they may ask you, just tell me the stage of the endometrium, whether it is proliferative phase or whether it is secretory phase. Guys, in this image, if you can see, there is this one single white line. Okay, that one single white line is the endometrium. If you can able to see only one single white line, that is early proliferative endometrium. Okay, that's a proliferative stage, that too early proliferative stage. Now, in the second image, you can see this 3-line appearance. Okay, this 3-line appearance of the endometrium. This 3-line appearance is also known as a trilamellar stage or trilamellar endometrium. Trilamellar endometrium is going to be seen in late proliferative phase, that is almost during the time of ovulation. Okay, and in the third picture, you can see that the endometrium is so much thick, it's not showing any lines, it's so much thick. So this stage is the secretory phase or secretory endometrium. If you are seeing only one single line, it is early proliferative phase. If you see a trilamellar stage, it is late proliferative stage or at the time of ovulation. If you are seeing a thick, very thick endometrium, it is a secretory phase of the endometrium, and the same can be seen even in these pictures which I am showing you right now. Here it is one single line. Here you can clearly see that this trilamellar endometrium, and in this image you can see only a thickened endometrium seen in the secretory phase of the menstrual cycle. Now, after this, guys, here you can clearly see the furning appearance of the cervical mucus, which will be seen during the proliferative phase of the menstrual cycle, and in the second image, it's very clear that the cervical mucus is stretchable. Okay, so stretchability and firming are due to the effects of estrogen which are seen in the first half of the menstrual cycle, that is the proliferative phase. Now after this, the management of anovulation. I have already told you that anovulatory infertility is the most common cause of infertility, and this anovulatory infertility is easily treatable. How we are treating it? We are treating it by giving ovulation inducing drugs. So what are the available ovulation inducing drugs? There can be questions something like this. All of the following drugs can be used for ovulation induction except. So everyone knows our favorite drug is the clomiphene citrate. It's the previous drug of choice for ovulation induction. But now in the recent updates, we clearly say that the letrozole is the drug of choice for ovulation in a female who is having anovulatory cycles. So clomiphene citrate, we all know clomiphene citrate is an anti-estrogen. Okay, it's going to block the estrogen receptors in the central nervous system, so it decreases the negative feedback to the follicle stimulating hormone. So the mechanism of action we have already discussed in a separate video, but here what I am trying to put into your mind is for ovulation induction we are using clomiphene citrate, letrozole. Okay, letrozole is an aromatase inhibitor, and HCG injection. So why we are using HCG injection for ovulation induction? How HCG is going to be helpful in this condition? Guys, please concentrate. HCG, human chorionic gonadotropin. See, it is functionally equivalent to luteinizing hormone. We all know that luteinizing hormone is the one which causes resumption of the meiosis 1 and it causes ovulation in a normal female. Now what I am trying to put into your mind, HCG, human chorionic gonadotropin, is functionally equivalent to LH. So the moment I gave HCG to this woman, it just simply like I am giving the luteinizing hormone. So there can be ovulation in this female who is not ovulating. Okay, so HCG injection can be given, and human menopausal gonadotropin. The topic of menopause, I have clearly said you what exactly is human menopausal gonadotropin. Human menopausal gonadotropins are nothing but the FSH which was extracted from the urine of menopausal female. See, menopausal female urine have lots of follicle stimulating hormone. This follicle stimulating hormone is extracted and we make human menopausal gonadotropin out of it. So human menopausal gonadotropin is nothing but the follicle stimulating hormone. So if you give human menopausal gonadotropin to a woman who is not ovulating, so this FSH, follicle stimulating hormone, it stimulates the ovarian follicles to grow. So the ovarian follicles, they are growing and the development of the follicles will cause the ovulation. Follicles are growing, so whenever they reach a proper size, you can give HCG. So this HCG will cause the ovulation. So it can be used. And GnRH analogs. So gonadotropin releasing hormone analogs, you are giving it in pulsatile doses. So if you give them in pulsatile doses, that will stimulate the anterior pituitary. So that anterior pituitary will produce FSH, LH. So this FSH will come and act on the ovary, so that ovarian follicle grows. And whenever the ovarian follicles are growing, they will give the positive feedback for the release of LH, and that LH will come and causes the ovulation. So at the end of the day, what I am trying to put into your mind is what and all the drugs which we can use for a female who is not ovulating. So we can use clomiphene citrate, letrozole, HMG injections, HCG injections, and gonadotropin releasing hormone analogs in a pulsatile doses. Now completed. The topic of anovulation completed. Now let's talk about what if a female had decreased ovarian reserve, which means in her ovaries all the follicles are exhausted. That's a premature menopause. So how to know whether she had a proper follicular count or decreased follicular count? So there are certain tests which are very important for the exam. They can ask you all of the following can be used as tests for ovarian reserve. So please concentrate now. If her follicle stimulating hormone levels are more than 40 international units per ml, which means so much amount of FSH. What is the logic here? See, if her ovarian follicles are exhausted, all her follicles are burned out. Now follicles gone, so there is no estrogen. Whenever there is no estrogen, negative feedback on FSH is lost. You know, estrogens give negative feedback to FSH. If estrogens are not there, there is no negative feedback. What happens? Follicle stimulating hormone level raises. How much raises? More than 40 international units per ml is an indicative of premature ovarian failure. In the same way, we know that the granulosa cells of the follicles are the ones which makes the inhibins. So, no follicle, no granulosa cell. No granulosa cell means no inhibin B. So, inhibin B levels less than 45 picogram per ml means it's an indicative of premature ovarian failure. Her follicular count is going down. Now, clomiphene citrate challenge test. Now, if I am giving clomiphene citrate to her, it's a challenge test. So, she should ovulate. If she is having proper follicular count, like many number of follicles should be stimulated. Under controlled hyperstimulation of the ovaries, there should be more number of follicles ovulating. But you are doing clomiphene citrate challenge test, still she is not ovulating, which means there is decreased ovarian reserve. And a very important test out of all the tests for ovarian reserve, if they ask you what is the best test, what is the best qualitative test, out of all the tests, it's the serum anti-Mullerian hormone test. Just by checking the anti-Mullerian hormone levels, we can know whether there is premature menopause or not. Or also you can do just the antral follicular count. Okay, we are counting the antral follicles. Now, if you are just counting these antral follicles, if you are having a good number of antral follicles, if you can see the antral follicles, which means she is having the follicular load in the ovaries. But if you couldn't able to find the antral follicles, which means that the follicles are not present, the follicles got exhausted. So you are counting, which means quantitative test. So if they ask you, out of all the ovarian reserve test, which test is a quantitative test? Quantitative test is antral follicular count, and which test is qualitative test and best test, that is serum anti-Mullerian hormone levels. So we have completed the management of anovulatory infertility, and also we have completed the topic of ovarian reserve tests. Now in the next video, let's discuss a few more important causes of female infertility. Okay, thank you.